you for that. Thank you for that kind introduction. And I do plan to come back someday, so don't worry. I think what I would consider myself is on loan to the United States for the current time, but I will be back at some point. So can everyone see my slides? Nice. Okay. Yes. Okay, so here are my disclosures. And of course, one of my disclosures is I'm not a cardiologist, but certainly I will be speaking to you about some of the cardiovascular issues that our breast cancer patients face. So the objectives over the next 45 minutes or so were to discuss how do we identify patients with breast cancer at risk of cardiovascular toxicity? What about prevention and monitoring strategies for those patients who are at risk? What are the recommendations for surveillance in this population? And then I'll end by briefly talking a little bit about a multidisciplinary approach to the management of these patients. So just in the way of a bit of background, about 30% of patients receiving cancer therapy will experience some form of cardiovascular complication, whether that be LV dysfunction, heart failure, arrhythmias, hypertensive crisis, or so on. We know that in anthracycline-treated patients, the incidence of significant cardiotoxicity, often we think of as heart failure, can be as high as 5 to 10%. And we also know through learning about trastuzumab and the impact of that while this is not commonly associated with heart failure, only 2%, about a third of the patients in the community setting or actually outside of a clinical trial setting can develop asymptomatic left ventricular dysfunction. But we also have to remember that it's not just breast cancer that our patients face. Cardiovascular disease, and these are statistics from the US, but we can sort of divide by approximately 10 for Canada because I think we're similar. Cardiovascular disease affects about 48 million women, while breast cancer impacts 3.3 million in the United States. Age-adjusted mortality rates from coronary heart disease and stroke are higher than that of breast cancer. So while breast cancer is important, our patients are also dealing with these risks. And importantly, as we see longer-term data from our patients who've surviving having had breast cancer, particularly in older postmenopausal women, we're now seeing mortality risk due to cardiovascular disease surpass the risk of recurrent breast cancer. And so we can't have to think a little bit outside of the box and not just about breast cancer recurrence and the issues around that, but what are some of the cardiovascular issues that our patients face? Well, it's important to realize that cardiovascular risk is not stagnant. It's actually on a continuum. So while we often, as oncologists, think about the risk of a cancer therapy that we're offering our patients and what that might do, our patients often will come to us with pre-existing risk factors. So they may have hypertension, they may have diabetes, they may have pre-existing cardiovascular disease. We then expose them or treat them with a cancer therapy that may exacerbate that or contribute to that risk. And then, of course, in long-term survivorship, they may experience toxicities related to treatment that they had 10 to 15 years ago, such as radiation, which we know for left-sided breast cancer may not be a problem up front, but years down the road can lead to things such as valvular heart disease. So it's important to think about not just the present time when we're seeing them in the clinic and giving them drugs, but well, how do they come to us and what happens after they complete their treatment? We've seen certainly a number of different classes of drugs that have emerged and are available to us in the clinic today. And just wanted to highlight some of those classes of drugs. We're very familiar with anthracyclines and HER2-targeted therapies and the impact they can have on left ventricular dysfunction. And I'll be talking about that a little bit more. But we also still use capecitabine, which can cause coronary vasospasm. PI3 kinase inhibitors can cause a metabolic syndrome. CDK4/6 inhibitors, in particular, ribociclib, is associated with QTc prolongation. And then some of the more modern therapies, such as some of our HER2 TKIs, can certainly cause left ventricular dysfunction. HER2 antibody drug conjugates have also been associated with this. And I'm going to talk a little bit about checkpoint inhibitors and their impact on the cardiovascular system. So all of these, while they've improved clinical outcomes in our patients with cancer, can lead to some form of cardiovascular toxicity. It's with this in mind that a number of our professional societies over the last several years have published guidelines, including ASCO, the European Society of Cardiology, ESMO, as well as, I'm proud to say, the Canadian Cardiovascular Society, all really trying to help us guide our patients through their treatment, not only that ensure that they get the best treatment, but we sort of promote their cardiovascular health, at least prevent significant cardiovascular toxicity. Building upon these older position statements and guidelines in 2022, the European Society of Cardiology, in collaboration with a number of other societies, including the International Cardio-Oncology Society, published an updated guideline on cardio-oncology. This was truly an international effort, and I'm proud to say that there were representatives from this group from Canada, including myself. It says I'm from the UK. I'm really not, but maybe my dad was born in the UK. But suffice to say, this was really a global sort of effort that occurred during the pandemic. We never had an in-person meeting, and this was all done through WebEx meetings. And so it was quite an accomplishment, 131 pages. I'm going to, for the purpose of today, just walk you through some of the highlights of how this document can help us take care of our patients in the clinic today. This guideline has 272 new recommendations. So obviously it is quite an extensive piece in terms of recommendations, but I'm going to highlight what I think is important as terms of breast cancer treatment. When we think of our patients, and I alluded to this previously, when they come to us with a new cancer diagnosis, it's important to think about what their baseline risk of cardiovascular toxicity is. And we're going to talk a little bit about how we determine that. Then they start on their cancer treatment, and how do we manage some of their pre-existing cardiovascular risk factors and cardiovascular disease, and how does that influence what we can offer our patients? And then importantly, into long-term follow-up, how should we be following patients to try and at least detect early any long-term cardiovascular issues? So I'm just going to walk through this one case to maybe highlight some of the ways that we can think about this. So Linda is a 45-year-old premenopausal woman who self-detected a left breast mass, which on biopsy was an infiltrating ductal carcinoma. She has a smoking history, diabetes and hypertension, and a body mass index of 35. She performs less than 60 minutes per week of exercise. On biopsy, or clinically, you can see from her biopsy, this is a T2, N1, M0, grade 3, infiltrating ductal carcinoma that's ER positive, HER2 3+. So as your oncologist, her oncologist, you schedule her to start neoadjuvant dose-sense AC paclitaxel with trastuzumab and pertuzumab with the Taxol portion of her treatment. Her baseline echocardiogram is 53%, and her GLS, which is global longitudinal strain, is -14%. So global longitudinal strain really reflects the deformation of the left ventricle. So normal would be in the range of 17 to 19%. The closer it gets to 0, the worse the left ventricular function is, because there's less change between diastole and systole. So when should Linda's cardiovascular risk be assessed? And this is the first thing I think that's important about this particular guideline. The guideline says that cardiovascular toxicity risk stratification should occur before starting any potential cardiotoxic anti-cancer therapy. And I think that's important because while we think about, yes, we're going to give her anthracyclines, and we know that there's a sort of lifetime limit that you can give of anthracyclines, are there other things that we should be considering when thinking about our risk? So first recommendation is assess your risk before starting your treatment. Well, you did an echocardiogram and you saw that her left ventricular ejection fraction was about 50%. So that seems pretty good. But is that enough to determine her risk? Well, how do we assess her risk? And I think we as oncologists put a lot of weight on the echocardiogram, and if it's normal, we think we're okay. But in 2020, the Heart Failure Association of the European Society of Cardiology came out with baseline cardiovascular toxicity risk assessment tools that took into consideration not only the cancer therapy that our patients are receiving or about to receive, but a lot of the demographics and pre-existing risk factors for these patients. So for instance, are they older? Do they have pre-existing cardiovascular risk factors? Do they have cardiovascular disease? What about lifestyle factors such as obesity, smoking, inactivity? And have they previously had any cardiotoxic therapies? And so what this tool did is it took these 7 classes of drugs, including anthracyclines and HER2 targeted therapies, and developed risk factor scores being anywhere from medium, high, or very high. And that then you would, for each individual person, determine the risk assessment score, and that would give you an idea of what the risk of cardiotoxicity would be from the treatment. So to make it easier, I've already pulled up here the risk stratification performer for anthracycline-based chemotherapy. And our patient that I just presented has a borderline LVEF. She has hypertension and diabetes. She's a current smoker, and her BMI is over 30. So each of those factors individually confers a medium risk. But if you add up all these medium risks, she has at least 5 or more of these risks, that actually places her in a higher risk group. And with that high risk, the score, the risk of cardiovascular toxicity, at least in the future, is somewhere between 10 and 19%. So perhaps a little bit higher than we would have thought when we first looked at her history. So then if you say that this patient is at high risk and you're using this tool to determine that, what do you do with that information? Well, for those low-risk patients, they would presumably go ahead and start their cancer therapy as planned, and you wouldn't be too worried about cardiovascular risk and unless something happens during their treatment. For those who are moderate risk, you might consider a bit closer surveillance. But for those patients who are high or very high risk, the recommendation is that these patients be referred to a cardiologist or a cardio-oncologist so that there can be a discussion held about the risk-benefit balance of any cardiotoxic treatment, and more importantly, to help the oncologist manage some of the cardiovascular risk factors. So for instance, maybe they can improve their left ventricular ejection fraction. Maybe their diabetes is not well controlled, and or their hypertension needs to be better controlled. In addition to these things, you might also consider cardioprotective strategies. Now, what do we mean by cardioprotection? Well, this is actually a very nice review article that was published in JACC Cardio-Oncology last year, looking at preventative strategies. So for those patients at risk, how can we prevent the toxicity rather than waiting for it to happen and then referring our patients to a cardiologist? There are general things that we can recommend to patients, such as lifestyle changes, smoking cessation, weight loss, exercise, healthy diet, and so on. But medications also may come into play here, and they may actually be beneficial or provide some benefit to our patients. And so I'm going to just show you some of the current recommendations around that, but they can include things such as beta blocker, angiotensin antagonists, statins, there's less evidence for, and desrozoxane we can also discuss. So here are the current recommendations from the ESC guideline. So for patients, particularly those at high risk, the recommendation is always try and minimize the use of cardiotoxic drugs. And of course, that makes sense. All patients should have management of their cardiovascular risk factors and any pre-existing cardiovascular risk disease. And there's less evidence to support this, consideration of ACE inhibitors or ARBs or beta blockers in this population. Now, I want to point out here in these recommendations that you'll see that there's classes and there's levels of recommendation. So the class 1 would represent the fact that there's good high quality evidence that this is a good recommendation. In the yellow are the ACE inhibitors, ARB and beta blockers, indicating that this is a reasonable or should be considered, but the level of evidence in this area, particularly in cancer patients, is not as high as we see in the non-cancer patient population. They also recommend consideration of desrozoxane. As we know, this medication is the only medication approved for the prevention of anthracycline-induced cardiotoxicity, but the FDA label still says it's only approved in those women with metastatic breast cancer who've had at least 300 milligrams per meter squared of anthracyclines. Liposomal anthracyclines we do use mainly in the metastatic breast cancer setting, and I have not seen them used in the adjuvant setting, but we can always discuss that later during our question period. There's emerging evidence that statins may be of benefit, but the studies are early on. They're small studies. Some have been positive and some have been negative. But these are all things that your cardiologist or cardio-oncologist would help you work with you in terms of whether they might benefit your patient. So back to Linda. So that was her baseline echocardiogram, and she did have biomarkers done with showed a BNP of 57. She has a cardiology consult, and she started on carvedilol at that dose of 6.25 milligrams twice a day. So let's say she gets through her four cycles of AC, and she's just about to go on to her HER2 target therapy, pertuzumab, trastuzumab, and her taxane, and you repeat her echo. You do it pre-HER2 targeted therapy. And now you see her EF has gone down to 45%. Her global longitudinal strain is a little bit worse. So as it gets to be a lower number, that's worse in terms of LV function. And her BNP has gone up, which is a marker perhaps that the left ventricle is not working as well as it should. This is a question I often get asked. So at that point, do you stop all therapy or do you just proceed? And we know from the trials that were done with HER2 targeted agents in the adjuvant setting that this patient would not have qualified to continue and pursue HER2 targeted therapy. But we've learned a lot more about how these agents work. And so is it possible that we could actually allow her to proceed with her treatment as planned? Well, this is a study, a small study called Safe Heart that was originally published in 2019 and then updated in 2021. And what they did is they took 30 patients with either stage 1 to 4 HER2 positive breast cancer and treated them with the HER2 targeted therapy as planned. But prior to starting their HER2 therapy, they were seen by a cardiologist and patients were placed on a beta blocker and an ACE inhibitor. And early data from this study showed that 90% of patients were able to complete their planned HER2 targeted therapy, whether that be in the adjuvant or metastatic setting. 3 patients had what they called a cardiac event. One of them had a left ventricular ejection fraction that went to less than 35%. They've updated this study, a median of 42 months follow-up. Of the original 30, there's 23 patients that they were able to follow. 8 of the 9 with metastatic breast cancer remained on treatment. There have been a few deaths in the metastatic setting, but as you'll see in the to your right on that figure, we still have really 3 patients who experienced an adverse cardiac event, saying that this is a small study, but proof of principle that if these patients are closely monitored and if they're treated appropriately with medical therapy, certainly that they can safely proceed with their treatment as planned. So she started on valsartan, 80 milligrams per day. She continues her HER2 targeted therapy with close LV monitoring. How closely should you monitor them? Well, here's the current recommendations, and this is really as per the FDA label. Really, all patients, it's recommended, should have LVF monitoring, usually with an echocardiogram every 3 months while on therapy. For those at high and very high risk, consider doing one at 3 months post-treatment and then at 12 months. Now we know that especially during the COVID pandemic, not all patients had this intensity of monitoring. And we also know there are ongoing studies looking at the low and moderate risk individuals to see if we can de-escalate some of the imaging that is currently being recommended. And so we will wait to hear the results of those studies, because I do think in the lowest risk individuals, we probably do not need to be doing echocardiograms every 3 to 4 months. So there she is, her LVEF is 52%, and she goes to surgery and has a pathological complete response, followed by a breast radiation. She completes her trastuzumab, pertuzumab, and then she is started on tamoxifen. So what do we do with these patients once they've finished their cancer therapy? In this case, and this is really for all our patients, irrespective of what therapy they are, if they're at high or very high risk at the baseline, which she was, the recommendation is annual cardiovascular risk assessment. And although the quality of evidence is not as high, consider echocardiogram at years 1, 3, 5, and then every 5 years thereafter. Now, there is much stronger data in the pediatric population to make these recommendations. I would say in the adult population, we do not have a lot of long-term data to support this, but this is the current recommendation based on really expert opinion, and further data is clearly needed in this area to show that this is beneficial for our patients. 3 years later, she presents with abdominal pain and fatigue, and imaging reveals multiple liver lesions and bone metastases. She has a biopsy of the liver lesion, which shows metastatic carcinoma consistent with her original breast primary. And the biomarkers are ER positive, PR negative, HER2 3+. Now she has an echocardiogram just done because they decided to follow the guidelines and did a 3-year echocardiogram, and her LVEF is still 52%, GLS is -14. So pretty stable. And she, of course, had continued on the medication. So let's look at antibody drug conjugates. They have clearly made a huge difference in how we approach patients in the advanced or metastatic setting. Certainly in the first line, as she's greater than 12 months after completing adjuvant therapy, we would still offer her a taxane in combination with trastuzumab and pertuzumab. But beyond the first line setting, there are now a number of options in terms of antibody drug conjugates. As you can see here, this was presented at ESMO just last year. Trastuzumab deruxtecan is now considered the best agent as a second line, followed perhaps by TDM1 or the HER2 climb regimen with tucatinib, trastuzumab, and capecitabine. So depending on what they've had and when they relapsed, our patients hopefully will have access to many of these lines. And then in the fourth or later line setting, if patients have access to that many lines, there are other drugs such as margetuximab and chemotherapy. The question is, though, what has been the data demonstrating the cardiovascular toxicity of these antibody drug conjugates? So last year in JACC Cardio-Oncology, we published a very short article on how to treat HER2 positive metastatic breast cancer with these agents from a cardiotoxicity perspective. And I think really what you see there is you see from the study so far, like Destiny 3, the reported cardiovascular toxicity has been relatively low. So for instance, with TDXD, the left ventricular dysfunction that was reported was only 2.3%, TDM1 0.4%. And so relatively low rates of cardiovascular toxicity. However, when we look at this, we have to keep in mind that there's been limited experience in the real world setting. So now we're seeing our patients go through multiple lines of HER2 targeted therapy. And I think clearly longer term follow-up is needed. Also, of course, our patients, such as the one I presented to you, would have been excluded from participating in any of these trials. So our older patients that have a borderline left ventricular function may be at higher risk than is really indicated by these studies. What about the HER2 oral tyrosine kinase inhibitors? Certainly, we have several of those available to us now, tucatinib, lapatinib, neratinib. In general, the cardiovascular toxicities associated with these drugs has also been relatively low. Lapatinib has been associated with a cardiac adverse event rate of about 3%, which is mainly left ventricular dysfunction. Neratinib, it's really not shown a great deal of cardiovascular toxicity, and tucatinib, modest. And so that is just, interesting in terms of what's been reported in studies. But as I say, again, it would always be really nice to see a little bit of what happens with our patients in the real world setting, because many of our patients on these therapies would have been excluded from the clinical trials. Now, the other question that comes up quite often is, how do you approach cardiac monitoring in patients with HER2 positive advanced breast cancer? And here is the recommendations that I showed you earlier, but you really have to go to the fine print to see what are the recommendations for this patient population. So currently, and although there is very little data, the recommendation is that in low and moderate risk patients, an echocardiogram every 6 months would be reasonable after the first year if there's a normal LVEF assessment. In high and very high risk patients, echocardiogram every 2 to 3 cycles may be considered depending on the absolute risk and local availability. The caveat I'll say is there's not a lot of evidence to support this, but this is to be felt what is reasonable. And if I remember, when I left Ontario, the CCO was requesting that patients have echocardiograms every 6 months. So she commences on Taxol, trastuzumab, and pertuzumab with good clinical response and no change in her cardiac status. So she does exceptionally well. So I'm going to stop talking about HER2 targeted therapy and anthracyclines and switch gears significantly and talk a little bit about immune checkpoint inhibitors. So as we know, immune checkpoint inhibitors have really revolutionized the treatment of solid malignancies. And we have a number of these checkpoint inhibitors now that are either against PD-1, PD-L1, or CTLA-4. There are many now FDA-approved indications for checkpoint inhibitors. And of course, breast cancer is there, and the pembrolizumab was one of the last ones, I think, to join this growing list of indications for these drugs. Immune checkpoint inhibitors have received a lot of publicity and press because of the risk of myocarditis associated with this class of drugs. However, just remember that while myocarditis seems to be more popular in terms of awareness, immune checkpoint inhibitors can be associated with pericarditis, pericardial effusions, arrhythmias, heart failure, and so on. The incidence of myocarditis is relatively low, anywhere between 1 to 2%. It tends to occur early in the onset of treatment for patients, and the fatality rate, unfortunately, can be quite high. Now, it used to be reported as high as 50%. With earlier identification and more aggressive management, the fatality rate associated with this toxicity is now in the order of about 30%. Interestingly, in patients with fatal myocarditis, 93% of patients only received 1 or 2 doses. So again, just alluding to, it tends to occur early in the course of treatment. Now, does it occur in breast cancer? And this is sort of was data that I just found from a study published last year in Cardio-Oncology. This was a study done from the Royal Marsden in the UK, where they looked retrospectively at patients, almost 2,500 patients treated with ICI therapy over a 6-year period. 110 referred to cardio-oncology service, 89 patients experienced an adverse cardiovascular event. And of those cardiovascular events, myocarditis was the most common diagnosis. So the numbers become increasingly small as you go down. But I did want to point out that in green under that arrow, there were actual breast cancer patients that were seen in the clinic with a diagnosis of ICI-induced myocarditis, although the numbers were small. Pembrolizumab was by far the most common ICI therapy that was prescribed. And of course, not surprisingly, there was a higher incidence of myocarditis when you combined immune checkpoint inhibitors versus single agent. So here's just an example of what you might see. This is a 56-year-old postmenopausal woman with clinically a 2.5 centimeter N1, M0 infiltrating ductal carcinoma, triple negative. Her oncologist recommends neoadjuvant therapy with a Keynote 522 regimen. And of course, now with the carboplatin shortage, we've reversed and we started with anthracyclines first, but carbotaxol with pembrolizumab followed by AC and pembrolizumab. She has a baseline echocardiogram that shows an LVF of 52%. So she presents to your clinic prior to cycle 3 of weekly Taxol carbo and her pembro, complaining of shortness of breath and chest discomfort. Her blood work's normal. Her ECG shows nonspecific T-wave abnormalities, and her repeat echo shows an LVEF of 50%. So not much different from her baseline, but her troponin is certainly elevated at 140 with normal being less than 14. So what places individuals at risk of ICI-induced myocarditis? Well, as I alluded to previously, if they receive combination immune checkpoint inhibitors, if they have immune checkpoint inhibitors in combination with other cardiotoxic therapies, such as if you gave it with anthracyclines, for instance, a history of prior myocardial injury, such as an MI or heart failure, pre-existing autoimmune conditions seem to place these individuals at risk, and also they have higher cardiac biomarkers to start with. The problem in diagnosing ICI-induced myocarditis is that the symptoms can be rather vague. So fatigue, muscle pain, fever, shortness of breath, palpitation, syncope, all of these can be can be chalked up to perhaps some of the chemotherapy regimens that we give. And so you really do have to have a high index of suspicion. Now, there are diagnostic criteria for myocarditis, and certainly this is not my area of expertise, but suffice to say that troponin elevation is quite common in myocarditis, but you can have normal echocardiograms. The diagnosis requires one major criterion, such as a CMR that is classic for myocarditis, and or two minor criteria, as you see there. So it really can be somewhat difficult. Hopefully at this point you have a cardiologist involved working with you, but clearly I think that people are much more aware of this diagnosis now. When patients do come in with chest discomfort, if they have biomarkers that are elevated, many people will start to think about this diagnosis. The question is, how do you manage it and what do you do with it moving forward? In terms of for patients starting on immune checkpoint inhibitors, they do recommend that all patients have an ECG and baseline cardiac biomarkers so that you have something at least to look at if they do get into trouble, and a baseline echocardiogram. So you can see that on the figure on the right, showing you that all those in green should be done at baseline, ECG, echo, cardiac biomarkers, and certainly a cardiovascular assessment. And really that helps you if they then present later with symptoms suggestive of myocarditis. If they continue to go through their therapy, depending on the length of time they're on their immune checkpoint inhibitor, you can see those at high risk. There suggests that maybe you do periodic biomarkers, but other than that, probably not a lot unless they present with symptoms. How do you manage immune checkpoint inhibitor myocarditis? So the ASCO guidelines talk about high dose steroids, one dose, and then if there's no immediate response, go for methylprednisolone for 1 gram a day for 3 days. The ESC guidelines really suggest pulse steroids minimum of 3 days up front, and I think that's what most people are doing now. They're giving up 3 days up front and then consider where they are, if they're improving or not. If they're recovering, you can consider switching to oral prednisone and then taper it over a number of weeks. If they are not improving, certainly there are other second-line immunosuppressive agents that can be considered, such as antithymocyte globulin, there's rituximab and mycophenolate, all these things. And by that time, certainly you will have cardiology involved in treating these patients as well. And then the duration of the taper anywhere to 4 to 6 weeks. And you can track their response with their cardiac troponins. So I think most people will do the pulse steroids now for a minimum of 3 days. Is that the best way to treat myocarditis? That's what we do today. I just wanted to highlight this study. This is a multi-center study being conducted in North America, and the PI is Dr. Tom Nealon from MGH in Boston. Recognizing that not everyone responds to pulse steroids, they're looking at those patients who were admitted to hospital and who did not get better within those few days, adding in a drug called abatacept to see if that helps improve their overall function. Abatacept is a fusion protein that inhibits T helper cells being activated. And this is the study schema. So patients are admitted to hospital, they're not getting better on their corticosteroids, and therefore we add in abatacept. They're randomized to abatacept or placebo. So 50 centers, I believe Toronto is one center at perhaps Princess Margaret. And certainly this will be interesting to see the results of this study. It's one of the largest studies I'm aware of looking specifically at how do we treat ICI-induced myocarditis. So I just want to spend the last sort of few minutes of my talk looking at cancer survivorship. So I've talked a little bit about risk factors at the beginning and risk stratification, patients then who are on therapies that may cause cardiotoxicity, and what we have to think about and be aware of. And certainly I've only mentioned a few drugs, and in the document, they cover many other different cancer drugs, but what happens to our patients afterwards and how do we monitor them? There are actually some recommendations on long-term surveillance in asymptomatic cancer survivors. So here you see that the recommendation for all of our cancer patients, whether they be at low, moderate, or high risk, is that they have an annual cardiovascular risk assessment, cardiology referral if they develop cardiovascular symptoms. And interestingly, and this is something new, is there is a recommendation that at 5 years, if they're still in your practice, they may be back to their family doctor by then, considering a cardiovascular toxicity restratification. So where are they at that point in time? And so that's something I think that we'll have to think about how we could do that logistically, but recognizing that that risk is a continual risk and doesn't decrease, even though our patients are further out from their cancer treatment. And of course, patient education and cardiovascular risk factor optimization are always important. As I alluded to previously, there are recommendations for around cardiac imaging, and in the highest risk patients, they do recommend imaging more frequently, although this is a class 2 recommendation with a much lower level of evidence. And so ongoing research is being performed in this area to try and determine the optimal frequency of imaging. For those individuals who develop cancer treatment-related cardiovascular toxicity during their treatment, if it's severe or very severe, the recommendation is they continue their heart failure therapy. And this was always a question that I remember asking my cardiology colleagues: if they're started on ARBs or beta blockers, do you ever stop, even if their cardiovascular health improves? And I think that's really an ongoing question. I think that depends on how severe their toxicity was, how quickly they recovered, and what are some of their underlying comorbidities, such as diabetes and hypertension and so on. So there are some recommendations around this. And of course, this is ongoing. Again, research is needed in this area to further delineate how we manage these patients beyond the end of their cancer therapy in terms of their cancer treatment-related cardiac dysfunction. Comorbidities, I think, is one area that I have often underappreciate the impact on our patients with cancer and their overall cardiovascular health. This was a paper we published last year looking at how we can sort of move away from that disease-centric model more towards a person-centric model, recognizing that our patients come to us with underlying genetics, lifestyle behaviors, social determinants of health, and environment. They then develop cancer, and then we expose them to cardiotoxic therapies, whether that be traditional cytotoxic agents, immunotherapy, radiation therapy, and that clearly has an impact on their overall risk of cardiovascular disease. They probably may have been, insulin resistant, that may contribute to them, their diabetes progressing, hypertension, and dyslipidemia, all of which can lead to increased risk of cardiovascular morbidity and mortality. And the management of cardiometabolic comorbidities associated with cardiovascular disease is really essential thing to consider, not only before, but during and after cancer therapy. And that's where we think we have to sort of work together to try and determine how we can do this. So how do we do this as oncologists? Certainly we have more than enough already that we are trying to manage in terms of the cancer therapy for our patients. And so this is where I think a team-based approach for cardiotoxicity management is essential. So in order to optimize both their cancer and non-cancer related therapy and their risk of cardiovascular disease, we need to think of the primary care team, oncology team, cardiology team, and then surrounding that whole team, the dietitians, the physical therapists, social workers, psychologists, exercise physiologists, really because it's anything that we do to an individual is going to impact other aspects of their health. So what we don't want to do is to cure these patients of their cancer only for them to die of premature cardiovascular disease. And so I've taken you briefly through the ESC guideline Cardio-Oncology. Essentially, the purpose of this document was to take the most up-to-date evidence and to put it into what I'll call a care pathway, as you see here, looking at baseline cardiovascular toxicity risk, how we manage patients during cancer therapy and how we monitor them in terms of their cardiovascular imaging, what happens to them after their therapy early on, and then in terms of long-term follow-up. And all of these will depend, of course, on what that patient brings to the clinic with them in terms of their past health and the type of cancer therapies that they're going to be exposed to. The ESC has their document in the form of a pocket guideline, is also available as a downloadable app. There is the guideline slide set as well as the essential messages. And what I didn't put on here is they've actually also recently published an information pamphlet that's very patient-friendly. So my take-home messages from this talk are really that cardiovascular toxicity is an important adverse outcome to be anticipated. And I think we really have to consider our approach whereby, as oncologists, we would wait till patients developed cardiovascular toxicity and then refer them to the cardiologist. Now we have enough information where I think we have to be a bit more proactive in saying, if they're at risk, is there some way we can not only give them the best cancer therapy, but prevent cardiovascular toxicity? Baseline cardiovascular risk assessment is really recommended for all patients undergoing cancer therapy, and prevention strategies should be considered, particularly for patients at high risk. Surveillance strategies should be based on the risk of cardiovascular toxicity, and I would say there's still ongoing work and research looking at what are the best surveillance strategies. I think that we have extrapolated a lot of information from the non-cancer patient population. And so it would be nice, we're starting to see more studies being done specifically in the cancer population. A multidisciplinary approach, I think, is really essential. I don't think as oncologists, we can be expected to handle all of this in our current workload, but it's important to consider how other members of our team, and I didn't mention also nursing is very important. Your pharmacist is extremely important as we look at drug-drug interactions. The exercise physiologist, if you have a nurse, advanced care providers, GPOs, all really should be knowledgeable and aware of how we can prevent or at least assess for risk of cardiovascular toxicity and actually essentially promoting cardiovascular health. And then, as I already alluded to, further research is needed to identify new and more targeted interventions. This is a QR code here. This QR code is for the ESC Cardio-Oncology guideline. Certainly welcome to review it, 133 pages of it. But importantly, the guideline has been developed so that you can approach certain aspects of it and really go to those sections of the guideline that might be most relevant to you, depending on the tumor type and the class of cancer therapy that you are prescribing. So the last thing I wanted to remind you of, and certainly I was given this slide, is that in order to get your CME credits for this event, please scan this QR code, and you should be able to complete the survey submitted for your CME credit for this talk. So with that, I'll conclude, and I think I've left a few minutes for questions. Thank you.